Good afternoon, my name is Brianna Castro. I am an FTO paramedic with Cumberland County EMS, and today I'm going to be showing you all how to perform orotracheal intubation via both direct visualization and video laryngoscopy. To start out, some reasons that we would intubate a patient: if there's any sort of respiratory failure, if they have any sort of airway management concerns, so if there's swelling secondary to anaphylaxis or a burn, in times of like cardiac arrest where we would want to maintain an airway, anything that you want to or feel as a provider you need to secure their airway for ventilatory purposes. Equipment that we're going to need: start off with BLS before ALS. We have our BVM. I also brought a bag valve mask because prior to us intubating our patients, we want to make sure that we are properly pre-ventilating or pre-oxygenating our patients, whether that be via a non-rebreather or with a BVM attached to our oxygen here. I also have grabbed our equipment for the intubation. So we have our endotracheal tube. This is a size 6 for this mannequin. We have our endotracheal tube. We also have a stylet. Can use a stylet or a bougie, whichever personal preference you have. When we're inserting the stylet, we want to make sure that we are not going past the eye. So you can see my stylet ends here, and the eye of my tube starts right there. I also have a 10 cc syringe used to fill up our balloon, just like so. I have grabbed end tidal for placement confirmation, as well as confirmation of successful ventilatory status following the intubation. I have our disposable handle. I have grabbed 2 blades. This is a Mac, this is a Miller. You can tell they have some shape differences. The way that they fit into the anatomy of the airway is a little bit different. Again, you could use either one. This is personal preference as well. I have grabbed our securing device. In my service, we use Thomas tube holders, but you can use O2 tubing, you can use gauze, you can use tape, whatever your service has that's readily available. I also grabbed 2 different options that we have available for Cumberland County EMS in video laryngoscopy. So we have King Visions. These have a channeled or an unchanneled blade. So this is an option that we keep on all of our ambulances. We also carry CMAX the stores, and these are carried by our QRV lead medics. Okay, to begin, before we intubate, we're going to do a little bit of anatomy review. I think that you can see that. So here, yeah, I think you can see. So here's our nasopharynx region. Here is our oropharynx. Right down here, you can see this more anterior section. That is our trachea. This more posterior, that is going to be the esophagus. Anterior trachea, that's where air goes, that leads to our lungs. Posterior, that's the esophagus, that is where our food goes, that goes into our digestive tract. So when we're intubating, we are placing the tube right into the trachea so that we have access to the lungs. And then we'll go back to this picture. Perfect. So this is our airway. This is near right around our glottic opening. We have the tongue, which we are manually displacing with the laryngoscope. This area, you have the epiglottis. You can see this is the vallecula. This is the space right above the epiglottis. That is actually where we're placing the tip of our blade, more so with a Miller when we're directly maneuvering. And then right here on either side, these little white stripes, those are your vocal cords. And so that is what we are aiming to see when we are visualizing the airway, so that we know that we are placing the tube in the correct place because they sit right on either side of the glottic opening in the trachea. Okay, so anatomy's covered. We have all of our equipment. We have our partner manually ventilating our patient. We'll go ahead and get ready. Obviously you would have your PPE. I do not have mine on, but you would be wearing your appropriate PPE. We will take our method of choice. I'm gonna start with a MAC. This is a MAC 3. When you place these blades on, they do have a light to give you more visualization of the airway. I'm also going to grab my tube that I have pre-placed with my stylet. When we're placing the stylet, you do want to curve your stylet just a bit, just to match the shape of the airway, of the anatomy. And then I have my 10 cc syringe that is attached to the tube. So we're going to place our hand. There's a notch right here on the blade, or on the handle. You're going to wrap your pinky around there. These 3 fingers should follow suit, and then your thumb rests gently on the back. Intubation is definitely a skill of finesse. It is not a skill of brute force. So non-dominant hand has the blade, dominant hand has the tube so that we can maneuver this. We're going to take our blade, insert, sweep to the left. We are not rocking backwards. We're not brute force hammering. It is more pulling up to displace the tongue. It's a lot of wrist maneuvering, wrist strength. Once you visualize the epiglottis and the glottic opening, you do not want to take your eyes off of it, because as soon as you do, it will run away. So we're going to visualize. I see my epiglottis, I see my glottic opening, I see my vocal cords. Not taking my eyes off, I'm going to direct my tube into that opening. As I pull my hair out of the way, we're going to maneuver this. Okay, remove the blade, do not let go of the tube. We are going to remove the stylet. Again, not letting go of the tube. We're going to fill up our 10 cc's of air, and as we're holding this, we're going to remove it to keep all the air. If you were to fill it up and leave it, oftentimes it will backfill on you, and we don't want to unintentionally deflate our cuffs. Then we would place our end-tidal CO2 monitor onto the tube, and we would place our BBM onto that. Once we have this, again, not really letting go because we want to confirm placement before we secure it. We give a squeeze, and you can see that we are getting airflow into both lungs. This mannequin has definitely seen better days, but okay. So now that we have secured our placement, I would hand this off to a partner, a friend. And just take our tube holder, following your manufacturer's directions. Place this here. Secure this. Once we have this secured in place, then we will run this back there. Okay. And then again, just like with any other maneuvering that we do, we want to reconfirm. We would confirm placement by auscultating lung sounds, obviously any waveform on end-tidal, as well as listening for gastric sounds. So that is with a MAC blade. And then I'm going to show you a Miller, and I will use the King Vision to show you the video laryngoscopy. So we'll take our tube out. Deflate your cuff before you take your tube out. Take our tube out. we will replace our stylet. Again, not going past the eye, making sure we have our curve. Our syringe. And swap this out for a miller. Okay, checking our equipment, making sure our light works. All right, same thing, hand placement, pinky, wrap your fingers, place your thumb. This one, to visualize it passing the cords. I normally prefer a mat over miller, so it does take a little bit of a different technique, but it's important to be competent in both. Not letting out our tube, filling up our air, and we have lung sounds. You can see that we have no air moving in our gastric pouch. This time we will deflate our cuff before we pull our tube out. And it is more of a technique of lifting up versus lifting back. So when you place it, I'm gonna get down, get close, and be pulling up. So I'm not rocking backwards, I'm pulling up towards the sky to displace this way. You can see his head comes up off of it. Obviously, real people's heads are much heavier than our mannequin here, and they're secured better. So you would not have as many problems with that. Moving on to our CMAC. You can definitely see the light. I think I showed you guys the camera. So this one, you want to set your Mac in place. Your fingers fall into a similar position. Pinky's there. These curl, it has finger holes. So we're going to place the CMAC. And you can see on the screen, I don't know if there's a way for me to show you guys this. I can see on the screen where I'm at. So I'm looking on the screen. I'm not rocking back and hitting teeth. I actually have a bit of a gap. Taking my tube, just like butter. We're gonna remove our CMAC. Beautiful. So with any placement confirmation, we also want to be verifying where our tube is sitting. So this one is 22 at the teeth. It's not super secured in a way that you obviously would want to go pulling or jerking, but that balloon should keep it fairly safe in place with minimal movement, as well as will protect any like gastric contacts from aspirating into the airway. Contraindications for an intubation, any significant airway, facial trauma that you wouldn't be able to access right, or any failed intubation, then you would move into your Crikes and your other methods. If there are no questions, I think that is all. Thank you guys for watching this video. I hope you have a great day.